see. Dr. Nguyen, can you advance to the next slide?
Mm-hmm. Okay, it might have froze on me.
Uh-oh.
Is
There
this the
you
next? Okay.
Just taking a moment. Wonderful. So I'd like to welcome everybody to Family Medicine Grand Rounds. Today is September 2nd, 2020. And please don't forget to register your attendance and claim credit. Our event ID today is 246047. You have multiple ways that you can do this, so please give it a try, cell phone, smartphone, or even your computer, depending on how you're watching it. Next. Awesome. We'd like to thank everyone in advance for please muting your microphone once the presentation begins. If you don't mute, you will mute you. That's okay.
Did I go to this?
That's okay. We'll figure.
Do you want me to stay or go back?
Go back one more. The other part too is, of course, making sure that you're engaged with it, or you're attending to the presenter, and of course being engaged in the session. Dr. Nguyen has specifically requested that if you have questions, if you wouldn't mind holding them to the end. If you are afraid you'll forget the question, please place it in the chat box, and then at the very end, we'll all read the chat box. And then, of course, completing and submitting your session evaluation is important. It's important to Grand Rounds, and it's also important to the presenter. So if you could please complete that at the end, we'll remind you. Just a quick reminder that Family Medicine Grand Rounds is held in conjunction with our educational partner, which is South Central Area AHEC. And if you are requiring CME transcripts, please reach out to our local UTSCA office if you have any questions. They respond very quickly. Similarly, the next slide is about AAFP. Please make sure that we have your current AAFP ID so that you can get CME credit. And if you have any questions, you can also contact them.
Do you want me to go through this slide?
Yeah, go ahead and go to the next one. And then, of course, Dr. Nguyen and Dr. Wiemers have no relevant financial or commercial interest to disclose. And then, having said all of that, go ahead. I'd like to welcome Dr. Tran Nguyen, PGY3, as she presents top poems of 2019, empowering patients to manage their diabetes. Dr. Nguyen, please.
Yes. So I'm presenting, and Dr. Wiemers is my attending faculty. So we're gonna talk about diabetes today. Can everyone hear me? Okay. Alrighty. So the first objectives, we want to discuss the available options for targeting diabetes. And we're kind of focusing on the oral therapy and maybe include injectables as well. And then understanding advantages versus adverse effects of common diabetes medications. And then describe the strategies for selecting glucose-lowering medications as recommended by the American Diabetes Association, the ADA, and the European Association for the Study of Diabetes, the EASD. So the question we're trying to answer with this poem is, what do European and the US diabetes experts recommend regarding the management of adults with diabetes type 2? So we're going to look at randomized clinical trials, systematic reviews, and meta-analysis published in English between January 1st, 2014 to February 28, 2018. And this is the practice guideline that we are going over. So first and foremost, the consensus has been that we focus on the patient. So atherosclerotic cardiovascular disease is a leading cause of death in people with type 2 diabetes. And these patients tend to also have other risk factors such as hypertension, hyperlipidemia, obesity, CKD, physical inactivity, smoking. So we want the approach to diabetes to be multifactorial, to acknowledge acknowledge these patient characteristics, trying to reduce the ASCVD risk factors, as well as responding to patient preferences and barriers. So even if we have, very effective diabetes medication, if patients are unwilling or there are barriers that prevent them from taking their medication, it won't be effective. And then another thing, that patients with type 2 diabetes should be offered access to DSMES programs, which is diabetes, self-management, education, and support. So they gave us kind of like a chart here and a graph kind of showing, how to approach diabetes type 2. So you assess the patient's key characteristics. So that include their lifestyle, their comorbidities, their height, weight, A1C, how motivated they are, how depressed they are, and other cultural and socioeconomic contexts. And consider how those factors affect treatment, especially if you have someone who's obese, you might want to choose a diabetes medication that would lower weight. And then if, in someone who's elderly, you want to focus on a medication that wouldn't cause hypoglycemia. And then frequency, mode of administration, all those are important. If having the option to either, take an oral medication versus injectable, a lot of patients would, prefer oral, and then having maybe a once a day injection versus multiple times a day. So considering that when you're making the decision as well. And then, voicing these out to your patient so that way you can agree on a specific plan. And then, to prevent what's called clinical inertia, to, monitor progress every 3 months. And then for the DSMES support program, so that would meet with patient on a more frequent basis to monitor what is going on. Okay, next. Lifestyle management, including medical, nutrition therapy, and physical therapy, are recommended as first-line therapies and as co-therapy for diabetic patients. And then medical nutrition therapy include education and support to help patients adopt healthy eating pattern. And these include dietary quality and energy restriction. So diet and exercise, so this is not news. Healthy eating habits, diet like Mediterranean diet, DASH diet, all these diets can help patient, lose weight and help patient get a better control of their diabetes. And then I think the study have shown that Mediterranean diet is more effective than the DASH diet, low carb diet, low fat, low glycemic index, and high protein in terms of glycemic control. And then increasing physical activity also improves sugar control as well. And it's recommended that aerobic exercise, resistant training, and combination of the two can reduce frequency about 0.6%. We're going to take a look at the diabetes medication. So there's probably more diabetes medication than what I have listed on here, but it just goes to show that we have a lot of options available in terms of dealing with diabetes, and obviously, weight control, not necessarily a medication, but it's something that can help patient with their diabetes. And today, I think, you can tell from the title, we're kind of focusing our attention on the GLP-1 and the SGLT2 inhibitors. So I'm not going to go over everything that's listed on here. I just want to highlight some of the important, some of the key players in diabetes. And so we all know about Metformin. The thing about Metformin, it's been well studied, so we have a lot of experience, and we know what its profile is. It's very cheap. There's little risk for hypoglycemia. But when you're on metformin, there is concern that, you can get GI upset, you can get B12 deficiency, so that you would need to monitor the B12 level. There's a risk for lactic acidosis, and that risk is higher in patient with, poor kidney function. So you would have to renally dose the metformin for CKD. Other are DPP4 inhibitors, so the gliptins. It's also a very well tolerated medication. It's weight neutral. There's no risk of hypoglycemia. The disadvantages can be very costly, and then also risk of these other risks, including decay and heart failure hospitalization. We do try to avoid the sulfonylurea because of the risk of the hypoglycemia, but it's also a very cheap medication, and therefore it's something that can be considered if cost is a factor. TZDs, so pioglitazone, low risk for hypoglycemia, also very cheap. You are worried about the weight gain, and then heart failure and edema, so you would want to avoid in those patients. Those are the main thing I want to point out. And then the meglitinides, alpha glucosidase inhibitors are other options. And then on this page, I want to kind of focus on SGLT2 inhibitors, so gliflozin. So it blocks glucose reabsorption in the kidney, so it acts on the kidney. There's no risk for hypoglycemia. It can also help you to lose weight, and because you're, losing the sodium and preventing sodium reabsorption, you're also decreasing the blood pressure, as well as so you're decreasing the blood pressure, and it can also help with the heart failure. And this is one of the agents that we will talk about later on as well. There is risk for UTI and genital infections, and also risk for, because of its ability to decrease blood pressure, risk for hypotension and dizziness. And then the GLP-1 receptor agonists. So these are the glucagon-like receptor agonists. So shorter acting, you have exenatide, lixenatide. Sorry, I want to go back. The longer acting, you have dulaglutide, and then you have the exenatide extended release. The liraglutide, which is once a day injection, and the semaglutide. So as monotherapy, there's little risk for hypoglycemia. It can also help to decrease weight, improves cardiovascular risk factor. You do worry about GI side effect, and as we learned last week from one of the pharmacotherapy lecture, you don't want to take that medication if the patient, you don't want to give that medication if the patient has gastroparesis. And obviously it can be very costly, up to $1,000. So that's definitely something to consider. And then insulin, obviously, there's risk for hypoglycemia and weight gain. But if their A1C is very high, then that's one of the options that we could give patient. Okay. So first off, I want to talk about metformin. So metformin's first line for diabetes. For dosing, you start 500 once or twice a day with meals, and titrate up as tolerated to 1,000 twice a day. The max dose that they recorded is 2,550 milligram in the US, but anything over 2,000 is not as effective and can have a lot more side effects. So the benefits, again, is it's low cost, minimal hypoglycemia, potential for weight loss, and study have shown that it have a better CV mortality versus sulfonylurea, and a good safety profile. And again, disadvantages is lactic acidosis. You want to avoid metformin in severe illness, dehydration, if you have lower B12 concentration. And this is the study that has been done showing about the metformin. So I have a few, of these very straightforward cases. There's really just think to yourself what you think the answer would be. This is to kind of mainly illustrate a point. So we have a 54-year-old man with a BMI of 31 who works as janitor, diagnosed with diabetes type 2 about 10 years, currently on metformin 1000 twice a day. A1C is 8.0, fasting blood glucose around 160 to 200, normal renal and liver function. So kind of think to yourself, like what would you do next with this patient? Okay. So the major change from prior consensus reports focus on SGLT2 inhibitors and GLP-1 receptor agonists found to improve cardiovascular outcomes and secondary outcomes such as heart failure and progression of renal disease. In patients with type 2 diabetes with established ASCVD, SGLT2 inhibitors or GLP-1 receptor agonists with proven cardiovascular benefits are recommended as part of sugar control. So for our patient that we kind of discussed in the case, his BMI was 31. He's otherwise, no major risk factor. For him, I think the recommendation in the past would be, you have a lot of therapy that you can choose from to be able to maximize his glucose control. But because of these recent recommendations, we kind of want to pick a medication that's best for him, and that would be medication that would, promote his weight loss. And then he doesn't have any, of the ASCVD risk factor, but if he did, then, SGLT2 or GLP-1 receptor agonist would be a good medication for him. And another thing I wanted to point out is that, so diabetes is a progressive disease. So even if you have a patient, who's 10 years into diabetes and their diabetes has been well controlled in the past, eventually, with the beta cell impairment, eventually they might need combination therapy or other additional medication in order to control their diabetes. So going through this chart, so the first line in those without established ASCVD or CKD, first line therapy is metformin. So if the metformin is above the target, we could consider early combination, above 1.5%, consider early combination therapy. If the A1C is high, then either GLP-1, well, first off, like you would try to do general lifestyle advice, medical nutritional therapy, weight loss, etc. And then to control their diabetes, you would try to add either the GLP-1 receptor agonist or the SGLT2. And then if one or the other doesn't control, then you consider adding the other medication, basically. So the GLP-1 receptor agonists, again, their advantages is promoting weight loss. They don't cause hypoglycemia. They preserve beta cell functions, and they correct known pathophysiologic defects in type 2 diabetes. The disadvantages are subcutaneous injection. It can be very costly. There is increased risk of gallbladder events. And we're going to talk a little bit about the trial that kind of helped put the GLP-1 receptor agonist in the forefront here. So the first trial that looks at, well, it's not the first, but it's called LEADER. It's liraglutide effect in action in diabetes, evaluation of cardiovascular outcome results. So it's studying the effect of liraglutide, and here we're gonna look at the MACE, which is the major adverse cardiac events. So non-fatal MI, non-fatal stroke, and cardiovascular death. So they took over 9,000 patients, double-blind randomized trial into taking liraglutide versus placebo. The median follow-up was 3.8 years, and they found that, absolute risk reduction of 1.9%, and then with a hazard ratio of 0.87% for the MACE outcomes. And then for all-cause mortality, the hazard ratio was 0.85. So looking at this graph here, you can see that there's a difference between the placebo and the liraglutide. So liraglutide, for the primary outcome, the MACE outcome, have a 13% reduction for the outcome versus the placebos. So death from cardiovascular cause, there is 0.78 hazard ratio. So you're 22% less likely to die from cardiovascular causes on liraglutide versus the placebo. And these are the the hazard ratio for the non-fatal MI, non-fatal stroke, death for any cause. So on the liraglutide, you're 15% less likely to die from any cause on the liraglutide versus placebo. And this is the number for the heart failure, for hospitalization for heart failure. And then the next trial is the SUSTAIN 6. So this is looking at the semaglutide. So again, patient population 3297, diabetes with high cardiovascular risk. So randomly assigned to receive either semaglutide once weekly, 0.5 or 1 milligram versus the placebo. And looking again at the MACE outcome, major adverse cardiac events, the hazard ratio was 0.74 with the p-value 0.02 for superiority. So semaglutide, when compared with the placebo, have a 26% less likelihood of for the MACE events compared to the placebo. So 26% lower risk of the primary composite outcome of death from cardiovascular causes, non-fatal MI, non-fatal stroke than the placebo. And this is primarily driven by a 39% decrease in the rate of non-fatal stroke. So non-significant decrease in non-fatal MI, but there is no significant difference in the rate of cardiovascular death. Okay, so we have another graph. So again, the primary outcome hazard ratio 0.74, and this is the 26% difference over time. And then non-fatal MI, so the p-value is 0.12, so it was considered non-significant. And then for non-fatal stroke, the hazard ratio was 0.61, so this is the 39% difference between the placebo and the semaglutide. P-value here at 0.04, so it was significant. And then that from cardiovascular cause, p-value 0.9, so it's not significant. Okay, the third one we're looking at is EXCEL, exenatide study of cardiovascular event lowering. So it's compared exenatide extended release with placebo over 3.2 years. And this is a pretty large study, 14,752 participants, comparing once weekly exenatide to placebo. And so it was found to be non-inferior to the placebo, but was not superior to placebo with respect to efficacy. So the p-value is 0.06. The rates of death for cardiovascular causes, fatal or non-fatal MI, fatal or non-fatal stroke, hospitalization for heart failure, and hospitalization for acute coronary syndrome, and the incidence of acute pancreatitis, pancreatic cancer, medullary thyroid carcinoma, and serious adverse event did not differ significantly between the two groups. So these are some of the contraindication for GLP-1 agonists. It was thought that it can cause the increased incidence of, well, in pancreatitis, GLP-1 receptor agonists are contraindicated along with pancreatic cancer, medullary thyroid carcinoma. So again, looking at the graph, hazard ratio of 0.91, p less than 0.001 for non-inferiority, p-value of 0.06 for superiority. Okay, so case 2, 82-year-old female retired with a history of type 2 diabetes for 15 years, hypertension controlled with lisinopril 20 milligram, hyperlipidemia controlled with atorvastatin, currently on metformin 1000 BID, A1C of 8%. So just think to yourself what you would do for this patient. There's no really right or wrong answer choice here. So the main consideration for for someone who's elderly in the 80s is avoiding hypoglycemia. Severe hypoglycemia is associated with increased mortality risk and cardiovascular events. So it's okay to liberalize A1C target in the elderly. So instead of the A1C of 7, you could liberalize it. So for someone who's 80-year-old, their A1C of 8, that would be okay. And you want, for the diabetes medication, you do want to avoid sulfonylurea. And in this class, glyburide would carry the highest risk for hypoglycemia. Meglitinides, and then insulin. So insulin carries a greater risk for hypoglycemia than sulfonylurea. Okay. So choosing glucose-lowering medication if compelling need to minimize hypoglycemia in those without established ASCVD or CKD. So again, first-line therapy is metformin. And if the A1C is above target, in the case I presented, I probably would not do anything else. I would think 8 is a good enough A1C for someone who's 82. But if it was higher, like 8.9 or something, then we can consider additional medication. And then they offer more choices here. DPP4 inhibitor, GLP-1 receptor agonist, SGLT2 inhibitor, and TZD. So all these are, medication that you can to avoid the risk for hypoglycemia. And then if A1C is still above the target, then you consider the other medication that you haven't picked from the list. And then if you really need to have a better A1C control, then you consider insulin or sulfonylurea and whatnot down here. And then this is just to show if cost is a major issue, again, metformin, and then additional therapy could be sulfonylurea or TZD. Those two medication are very cheap, $4 or $5 a month versus something that can be like $400 a month. So we do want patients to, get better control of their diabetes. Okay, so we have case 3. We have a 61-year-old male with type 2 diabetes for 10 years on metformin 1000 BID, recently admitted due to osteomyelitis, treated with antibiotics. Patient and found to have AKI with elevated creatinine 3.6 in through-bond IV fluid. During hospitalization, metformin was discontinued and diabetes was controlled with Delamere and sliding scale. Upon discharge, creatinine is 2.1, GFR around 29, A1C 8.1%. So this is someone that we can see on our inpatient service. They come in for their foot problem, and then at the end of everything, they have bad kidneys. So managing diabetes in renal disease. So consideration for metformin. You don't start metformin if the estimated GFR is less than 45. And if it's between 30 and 45, you can continue the metformin. But if the GFR is less than 30, then you would discontinue. And then you would measure the eGFR at least annually and even more often if there is a risk for renal dysfunction. So I guess the point of that case is that metformin is not an option for him because his GFR was 29%. So you would have to consider another option for him. So other options include DPP4 inhibitors, SGLT2 inhibitors. So for SGLT2 inhibitors, because because they work on the kidneys, you need to have functional kidney for SGLT2 inhibitor to work. So they're not approved for eGFR of less than 45. So that would not be a medication that you would give this patient either. Another consideration is GLP-1 receptor agonists. So there's different medication in this class. Exenatide is contraindicated for GFR of less than 30. So that would not be a medication I would give him either. Other medication like liraglutide or semaglutide, there's limited evidence to approve or disapprove of it. So right now there's really, it's kind of caution if renal impairment, but there's no definite contraindication. And for TZDs, it's an option you can consider, but definitely, you know, it puts you at risk for heart failure, so you definitely want to monitor for fluid retention. Okay, SGLT2 inhibitors. So we have, you know, a bunch of medication in this class, dapagliflozin, canagliflozin, empagliflozin, etc. And the good thing about this medication is there's no risk for hypoglycemia. It decreased blood pressure because, you know, of its ability to, you know, get rid of the sodium. It also can help patients to lose weight. It, you know, kind of reverse the glucotoxicity, improve the beta cell functions, improve insulin sensitivity. And because it acts on the kidney, the mechanism is different from other medications, so it can be combined with other drugs. The disadvantages is that it puts patient at risk for UTI. There's risk for hypotension and dizziness. Doesn't require the kidney to work. There's risk for amputation and fracture in canagliflozin. And we're going to take a look at some of the studies behind these medications. So the first trial I want to focus on for the SGLT2 inhibitor is EMPA-REG, empagliflozin cardiovascular outcome event trial in type 2 diabetes. So this is a study of over 7,000 participants with type 2 diabetes and CVD, randomly assigned to 10 milligram or 25 milligram empagliflozin versus placebo once daily. So the hazard ratio turns out to be 0.86 for primary composite MACE, major adverse cardiovascular events, endpoint of non-fatal MI, non-fatal stroke, and CV death. So it resulted in significantly lower risk of death from cardiovascular causes, hazard ratio 0.62, death from any cause, hazard ratio 0.68, and hospitalization for heart failure, hazard ratio 0.65. So looking at this, so again, you know, patients who are taking empagliflozin would be at 14% less likely to die from, or I guess less likely to have the MACE adverse event compared to placebo. And then they're, let's see, 28, is that 28? 28% less likely to die from cardiovascular causes while on the empagliflozin versus the placebo. And here, yeah, death from any causes, 32%. Sorry, it went back. Oh. 32% less to die from any causes if they're taking empagliflozin versus the placebo. And then, you know, this drive is also pretty good for heart failure as well. And the interesting thing I wanted to point out with this graph is, if you notice, this is like 48 months, right? Just even starting the medication, you can see that there's a difference between the placebo and the empagliflozin. So the medication, you know, works kind of right away. So 6 months in, you can definitely see that there's already a difference between the two between the placebo and the empagliflozin. So that's a good medication that we would want to give patients if everything else, if cost is not a factor, I guess. Or and if they can tolerate the medication. The other trial I want to look at is the Canvas. So this is another big trial with over 10,000 participants. Randomly assigned to receive canagliflozin versus placebo, followed for 188 weeks mean. That's over 3 years, look like. So the rate of primary outcome, composite of death from CV causes, non-fatal MI or non-fatal stroke, was lower with canagliflozin than with placebo. Hazard ratio was 0.86. The p-value was less than 0.001 for non-inferiority, and then p-value of 0.02 for superiority. And then there's also a 40% reduction in estimated GFR, the need for renal replacement therapy or death from renal causes. And then there's also one thing to mention is that there is an increased risk of amputation. So 6.3, I guess, versus 3.4 participant per 1,000 patient years. And so this is why we kind of, some patient might be back away from the canagliflozin because of this risk of amputation. Hazard ratio of 1.97. And the risk of amputation mainly occurs at the level of the toe or the metatarsal. Okay, so death from cardiovascular causes, non-fatal MI, non-fatal stroke, hazard ratio of 0.86. So 14% less likely to die from cardiovascular cause, non-fatal MI or non-fatal stroke for a patient on the canagliflozin versus the placebo. And you can kind of tell from these as well. And then there was a study on canagliflozin regarding renal and cardiovascular outcomes in patient with diabetic nephropathy. So it was a double-blind randomized N of 4401, medium follow-up of 2.62 years. So they got to, the trial stopped after interim analysis. They met their endpoint, and so they stopped the trial. So the relative risk of the renal-specific composite of end-stage renal disease, doubling creatinine level, or death from renal causes was lower by 34%, hazard ratio of 0.66, p-value of less than 0.001. The relative risk of end-stage kidney disease was lower by 32%. And then the canagliflozin group also had lower risk of CV death, MI, or stroke, and hospitalization for heart failure. So this is kind of similar to the other study, the Canvas study, but this also kind of shows that canagliflozin had better outcome for a patient, with renal impairment. And then this is a study. The composite outcome here is looking at the effect on the kidney. And then end-stage kidney disease, it reduces progression to end-stage kidney disease. And here's dialysis, kidney transplantation, or renal death. Canagliflozin does better than the placebo. And then at the bottom, death from cardiovascular cause, which is what we're kind of focusing on with Audie's study. And the p-value is exactly 0.05. So choosing glucose-lowering medication in those with established atherosclerotic cardiovascular disease or chronic kidney disease. So so this is kind of like the main point of the paper. If ASCVD predominates, then you would want to pick either a GLP-1 receptor agonist with proven CVD benefit, or SGLT2 inhibitor would proven CVD benefit if eGFR is adequate. And for these, liraglutide has stronger evidence than semaglutide than exenatide. And then for SGLT2 inhibitor, empagliflozin had a little bit of better evidence than the canagliflozin. And then if A1C is still above target, then you consider adding the other medication. If heart failure or CKD predominates, then preferably you want to, if the GFR is adequate, then you want the SGLT2 with the evidence of reducing heart failure and our kidney CKD progression. And then if SGLT2 is not tolerated, contraindicated, or if eGFR is less than adequate, then you add the GLP-1 receptor agonist with the proven CVD and benefit. And this is kind of the combining everything, with established ASCVD or CKD. We talk about this. And then if they don't have established ASCVD or CKD, do you need to minimize hypoglycemia? Do you need to promote weight loss? Is cost a factor for them? And you kind of, tailor it to your patient. And then this is just a table with a bigger font, basically. I'm just going to mention briefly about intensifying to injectable therapies. So if you're having a A1C that's uncontrolled, and then if it's greater than 9 or 10 or something, you could consider initial injectable combinations like SGLT1 receptor agonists in addition with basal insulin, if you think that they won't be controlled with just like an oral medication or monotherapy. So consider adding the GLP-1 receptor agonist in most prior to insulin. And so you initiate and then you would titrate. So the initial dose is kind of varies across the class. And then you would try to titrate it up. And if that's not controlling their diabetes, then you would add a basal insulin. So you initiate the basal insulin and then you could titrate it up as well. For initiation for basal insulin, you can start at 10 units a day or do 0.1 to 0.2 unit per kg per day, and then titrate it up. And if it's still above goal, then you can consider adding prandial insulin with their meal. And then they did, suggest that you can start at 4 units a day or 10% of the basal dose. And you would give that, and then if the one-time prandial with meal is not controlled, then you can step it up even more. But you can go through this chart right here. And then it's important to kind of reassess pretty frequently when you're, on the injectable. So that way you can make sure that you don't want to put patient at risk for hypoglycemia. And you want to make sure that, they're getting, their DSMES support education, as well as controlling their diabetes, weight loss, if they need to, and then to make sure that there's no other factor that's a barrier for them to control their diabetes. And then considering orals with injectables, it's okay to continue metformin with injectables. And then if you're on insulin, consider reducing the TZD or stopping TZD when initiating insulin. And then if on sulfonylurea, because it puts patient at risk for hypoglycemia, reduce those by 50%. But really, you probably should just stop at sulfonylurea if you were starting on basal insulin. And then on SGLT2 can continue with the insulin. And even if you're on the insulin and you haven't started the SGLT2, you can start that if established CVD or as combination therapy to reduce A1C. And then if starting GLP-1 receptor agonist, stop the DPP-4 inhibitor. So they don't have a synergistic effect like you would think, because one is to increase the level of GLP-1 and the other is the GLP-1 receptor agonist. But because when combined, it has been shown that there's really not much difference. So if you're starting one, then stop the other. Okay, so kind of in summary, so metformin is still the preferred initial glucose-lowering medication for most people with type 2 diabetes. Stepwise addition of glucose-lowering meds generally preferred to initial combination therapy. So choosing medication added to metformin is based on patient preference and clinical characteristic, which include presence of established ASCVD and comorbidities such as heart failure or CKD, risk for specific adverse medication effects, especially hypoglycemia and weight gain, safety, tolerability, and cost. And so consider access, treatment cost, insurance coverage as well when you're selecting these medications. Some can be very expensive, and if they're very expensive, patient may not want to buy them, and then their diabetes will get out of control. If patient need injectable medication, GLP-1 receptor agonists are preferred to insulin. For patient with extreme and symptomatic hyperglycemia, insulin is recommended. Patients unable to maintain glycemic targets on basal insulin in combination with oral medication can have treatment intensified with GLP-1 receptor agonists, SGLT2 inhibitors, or prandial insulin. These are my references. Oh, I didn't go over the time. Okay. All right, any questions or comment?
Tran. So for some of the newer medications, do you have a sense of how much of that CareLink will pay for and Medicare?
So that's definitely like something to consider. I don't know about CareLink per se, but I think we've tried to like, it really depends on what kind of insurance patient have, right? And I know that some of the GLP-1 receptor agonists, they can be very costly. It can be like from $400 to $1,000, but I do not know how much of that CareLink will pay for.
Hey, Dr. Nada, this is Dwayne Davis. Just to jump in there, just going to say that Farxiga is on CareLink. Right now, they can get it through the bulk MAP program. And then in terms of GLP-1s, I think patients can get Victoza. We don't have Ozempic on the CareLink formulary yet. And there is a preference for Bydureon, but as Dr. Nguyen showed in the presentation, Bydureon or exenatide really doesn't have a lot of benefits. So probably want to stick with Victoza in that case.
Yes. So the Victoza is the liraglutide, and it's the one we would probably prefer.
Yeah, because the issue has often been you got to put them on something that they can actually get.
Yeah.
So I'd say, yeah, correct. I would say for Medicare, you shouldn't have any trouble getting your patients on any of these drugs. Same with Medicaid. Medicaid formulary, you can use Trulicity, which is dulaglutide. And then all three of our current SGLT2 inhibitors are preferred on Medicaid formulary. So Jardiance, Invokana, and Farxiga. And just some additional things you may not be aware of. So the Emperor trial just came out. That was for ertugliflozin, which is our newest one. That also has shown some cardiovascular benefit. And then regarding the black box warning on amputations for Invokana, that was just removed by the FDA about a week ago. It's not a black box warning now, but it's in your warning section. So patients still do have an increased risk of amputation on Invokana compared to the others, but a lot of it, when they look at the longer term trials and other trials, it may have been due to their selection of patients in the original trials, just something that they saw. So, because they really weren't looking for it, but it's something that they found. Also in regards to SGLT2 inhibitors, just for everybody's awareness, in terms of chronic kidney disease, we're probably going to start seeing more nephrologists start prescribing SGLT2 inhibitors, even in patients without diabetes. And also our cardiologists will also start to be prescribing SGLT2 inhibitors in patients with heart failure without diabetes. So you guys might start seeing this more. So keep in mind the side effects of SGLT2 inhibitors. One, they can increase potassium. Okay, so a lot of times we think of these as diuretics, and we think that the potassium might go down, but that's the opposite for SGLT2 inhibitors. Potassium is actually retained, so you might want to worry about hyperkalemia in patients on these drugs. Plus, they're also probably going to be on an ACE or an ARB anyway because of CKD, so just keep in mind out for that. In terms of diabetes and UTIs, SGLT2 inhibitors don't really increase UTIs, but they do increase yeast infections. So keep that in mind. And one last point I wanted to make with SGLT2 inhibitors, especially if you're in the ED, if a patient shows up with SGLT2 inhibitor, again, you might see what's called euglycemic ketoacidosis. So their blood sugars are normal, and so you may not think that there's anything wrong blood sugar wise, but you might want to check a ketone level and see if they're not in ketosis, all right, before you start jumping down some other rabbit holes. Just some.
They typically have an acidosis then, so that they have an anion gap, or do you know?
Yes, so they will have an acidosis, but you might go thinking it's something else, you know, that might fall into the acidosis picture.
Okay. So the SGLT2 inhibitors, the proposed benefit for the kidneys is what? I assume it's not all cause mortality, right?
You want me to talk? No, Dr. Nguyen, you want to go, or you want me to?
You can go ahead.
Okay. So it's a kidney benefit. So in terms of reducing or actually extending time to end-stage renal disease. So not out yet, but just kind of FYI, the KDIGO guidelines will be coming out later this year. They're actually going to recommend Invokana based on the Credence trial in use in patients with eGFRs less than 30. So it's going to be a big change coming out. So I know Dr. Nguyen presented they're not supposed to use SGLT2 inhibitors with eGFRs less than 45, but it's going to turn out that yes, we can use them in eGFRs less than 45. You'll want to use the low dose, of course. And then once a patient hits eGFR 30 or below, you'll switch them over to Invokana, continue the Invokana until dialysis. So that's going to be the recommendation that's going to come out this fall, just as an FYI. But yes, basically prolonged kidney benefit.
Any other questions for Dr. Nguyen?
Comments, questions?
Thanks, Tran.
Oh, thank you.
Definitely. In the absence of any questions, thank you so much, Dr. Tran, for Nguyen for presenting today. And again, evaluations, I think Nicole already sent the link out, so please complete it. And if you were unable to view any part of the presentation today, please take a look at our website. It is provided asynchronously.